a geografia de funcionamento do PEN Plus. Por outras palavras, há muitas instalações que prestam serviços ao abrigo do PEN. Temos muitas instalações de cuidados primários, comparativamente a hospitais distritais, mas no mesmo distrito temos também clínicas PEN Plus dispersas. E anteriormente também referi-me às cifras, onde para o PEN Plus as cifras são ligeiramente menores, mas para pacientes de diabetes tipo 2 e hipertensão o número é elevado. E como é que estão organizados estes serviços? Temos dois aspectos, alguns elementos são partilhados de serviços e outros aspectos que são únicos a um serviço específico. Por exemplo, a infraestrutura, onde são prestados esses serviços, são as mesmas. A mesma instalação hospitalar, a mesma infraestrutura, sistema de triagem na instalação sanitária é o mesmo, cadeia de suprimentos, laboratórios, radiologia, estão todos integrados na instalação sanitária, mas há elementos que são específicos a cada diferente tipo de iniciativa. A formação e mentoria para o PEN Plus, são diferenciados. Para o PEN Plus, a formação é ligeiramente mais especializada, porque estamos a desenvolver competências para provedores intermédios e temos diferentes populações de pacientes. O PEN Plus atende principalmente crianças com DNTs na sua fase incipiente e DNTs em adultos. E o PEN também tem um foco diferente. O PEN Plus é diabetes tipo 2, células falciformes e portanto temos investimentos partilhados no sistema entre esses dois sistemas que podem coexistir. Os programas, tal como indiquei, apoiam-se mutuamente. O PEN apoia o PEN Plus de uma forma em que o PEN já tem funcionários de DNTs capacitados para administrar as clínicas e as clínicas são boas para a detecção de casos e também decongestionam as clínicas PEN Plus. As PEN Plus reforçam também as clínicas PEN, porque agora estamos a incorporar um conjunto de competências avançadas para gerir DNTs graves e também tem serviços de mentoria que beneficiam as instalações PEN, melhoram o sistema de encaminhamento e as cadeias de suprimento. E tal como havia dito antes, estes são dois programas que se reforçam mutuamente e não se substituem. Deste diapositivo vamos ter as nossas mensagens a reter. Uma delas que eu ressaltei é que estas duas iniciativas podem coexistir, temos sistemas comuns como infraestruturas, cadeias de suprimentos que melhoram a eficiência, dias para o atendimento e que evita a sobreposição onde o paciente pode ter os cuidados ao nível necessário. Uma das lições a reter é que anteriormente, quando falávamos de DNTs, as pessoas se referiam-se apenas a hipertensão e diabetes. E muitas pessoas só sabem de DNTs e quando se diz que estamos a abrir uma clínica, as pessoas pensam que é uma clínica para hipertensão e diabetes. E porque na altura só apoiávamos DNTs na sua fase incipiente em adultos, mas agora com a introdução do PEN Plus temos um contínuo de cuidados no curso de vida. As crianças negligenciadas anteriormente por DNT estão cobertas no PEN Plus partindo da criança até adolescentes. Mesmo nos PEN Plus, quando bem geridos, podem também atender a adultos. Portanto, estas duas iniciativas providenciam cuidados integrados em todo o espectro de cuidados de saúde. Muito obrigado. Muito obrigada, doutor Alvin, pela interessante apresentação. Falou de mensagens que devemos refletir, mas o que eu colhi da apresentação é, primeiro, a importância da coexistência entre o PEN e o PEN Plus com encaminhamento cruzado, apoiando-se mutuamente, e disse acertadamente que os dois programas reforçam-se mutuamente e não se substituem. A integração do PEN e PEN Plus foi a mensagem fundamental a reter. Vamos ter no final uma sessão de perguntas e respostas. Portanto, podem registrar as questões que querem colocar aos apresentadores. Temos a seguir o Dr. Raul Remanjo, do, do, da Unicef, que vai falar de condições graves em crianças na sua fase incipiente. Desta feita, esta tarde, a esta hora, à tarde, depois do almoço, é de veras difícil. Vou tentar, nos 3 minutos que tenho, tentar despertá-los. Nós podemos ver a partir daqui que metade de vós estão já a dormir a cesta. Vou pedir para que se ergam, estiquem os braços e as pernas, podem até bocejar, na esperança de que os próximos 5 minutos serão úteis porque já tem circulação sanguínea a ir para o cérebro. Muito obrigado por atender a este meu pedido. Boa tarde, colegas. Sou Dr. Raul Bernel, do Unicef, lidero o trabalho na área da criança e de NTs. E é um grande prazer eu estar nesta conferência de Classe em África. Eu já estive nesta sala na última conferência, que foi a minha primeira, e vejo já progressos significativos por vários países, ministérios da saúde, OMS, a rede, parceiros de implementação e aqueles que apoiam as crianças, jovens, pessoas com DNTs. Portanto, reconheço o marco e a necessidade de continuarmos a avançar. Cientistas comportamentais dizem muitas vezes que devemos reiterar sempre a mensagem até vermos a mudança que queremos que aconteça. Esta manhã já tivemos uma sessão fantástica com os colegas na sessão liderada pelo UNICEF, onde ressaltamos a necessidade de integração, com risco de me repetir algumas das mensagens-chave. O colega da Libéria também demonstrou que isso pode ser feito e identificou de forma sistemática muitos pontos de entrada no NCH. Eles que utilizam como pontos de entrada para a detecção de episódios. Ele já fez metade do meu trabalho esta tarde ao tentar convencê-los porque a próxima fronteira do PEN Classe é assegurarmos a incorporação da gestão de DNTs na criança, na sua fase incipiente, que este foi o tópico da sessão do UNICEF esta manhã. O PEN Plus mudou fundamentalmente o que é possível para crianças e jovens que vivem com condições crónicas graves. Já há muito tempo, estas condições eram vistas como demasiado complexas, onerosas, especializadas e difíceis para começarmos mesmo a pensar nelas em contextos com recursos parcos como os vossos contextos, mas PEN Plus demonstrou que algo pode ser feito, um marco muito importante a assinalar. Mas hoje vou apresentar um fundamento, argumentando que a próxima fase do PEN Plus não visa apenas abrir e estabelecer mais clínicas PEN+. O próximo desafio é a edificação de sistemas em torno dessas clínicas que vão permitir a educação de crianças para cuidados, apoio domiciliar e, em última instância, sobreviverem e se ingrarem até a idade adulta. Já me referi a isto esta manhã. Uma observação que foi feita e anteriormente é que os programas de NTs são concebidos em torno da população adulta, de um modo geral, doenças cardiovasculares, hipertensão, diabetes, e os indicadores mesmo do, dos Objetivos de Desenvolvimento Sustentável centram-se no adulto, mas por outro lado, os programas de MCEH, sobrevivência materno, infantil, recém-nascido, imunização, sobrevivência da criança. E o que é que acontece então a crianças com condições crónicas, crianças com doenças falciformes, diabetes infantil e outras doenças congénitas? Que eles são, ah, escapam a esta rede, e a questão não é as crianças estarem ausentes do sistema, a miúde interagem com o sistema. O problema é que as suas necessidades não são adequadamente reconhecidas. Uma prioridade para a integração é fazer uso das plataformas NCH para a identificação e encaminhamento precoces, porque crianças com condições crónicas já interagem com o sistema de saúde muito antes do diagnóstico e antes mesmo da manifestação da sua condição, células falciformes, tipo diabetes tipo 1 e doenças cardíacas. E muitos deles, através de cuidados para o recém-nascido, imunização, NCI, contactos de rotina infantis, que são pontos de contato que representam imensas oportunidades para a detecção de casos, tal como o nosso colega de Oliveira demonstrou. As crianças já apresentam de forma reiterada, são apresentadas de forma reiterada ao sistema de saúde. Devemos utilizar essas plataformas para a detecção de casos, porque, tal como muitos de vós já referiram, quanto mais cedo nós identificarmos a criança, mais cedo o PEN Plus iniciará e mudar a trajetória da sua vida. E a segunda prioridade é efetivamente sobre o diagnóstico e cuidados longitudinais e retenção das crianças nos cuidados. As clínicas PEN Plus provinciais estão especializadas, mas as crianças não vivem nas clínicas, mas sim em casa, na comunidade, na escola, e muitos programas PEN Plus requerem cuidados ao longo da vida. E o desafio, portanto, é a manutenção de esta interação ao longo de anos e não semanas. Os programas de MCH já têm experiência na interação, controle. Temos quadros de saúde comunitários, serviços clínicos para o adolescente e sistemas de alcance comunitário, e estas medidas podem manter a continuidade de tratamento e acompanhamento. O segundo argumento, ao fazer é que os resultados a longo prazo não só são determinados por clínicas PEN Plus excelentes de alta qualidade, mas sim determinadas pelo fato de as crianças com famílias manterem-se ligadas a esses cuidados. As plataformas MCH podem assegurar essa interligação. A terceira prioridade que quero identificar é a capacitação das famílias pacientes. Crianças com condições crónicas passam uma pequena fração da sua vida nas instalações sanitárias. Grande parte de cuidado é domiciliar, o que significa que os provedores de cuidados são os membros mais importantes da equipa que providencia cuidados. E os programas MCH já há muito tempo apoiam a lactação, as mães lactantes e outros cuidados. E estas são as abordagens que nós precisamos para o PEN Plus poder penetrar nos domicílios, apoiar os pais e os provedores de cuidados para poder apoiar melhor as crianças com DNTs agudas. Em muitas áreas de doença, como aprendemos trabalhando com pacientes não de forma passiva, mas com parceiros ativos nos cuidados, funciona. E este é o mesmo princípio que deve ser reforçado através das plataformas MCH. Esta última prioridade de integração, apoio integral. As crianças não experimentam a saúde e dificuldades, uma doença de cada vez. Uma criança com diabetes tipo 1 pode também necessitar, ou a miúde necessita de aconselhamento nutricional, apoio em cuidados mentais e apoio escolar. E muitas famílias precisam também de serviço de proteção social. Uma criança com uma doença falciforme precisa do mesmo cuidado como uma criança que precisa de cuidados nutricionais e psicossociais. Portanto, muitos programas MCH proporcionam oportunidade para providenciar cuidados integrais e multidisciplinares, tanto à criança como às famílias, saúde, nutrição, desenvolvimento, educação e serviços sociais. E essa perspectiva integrada é exatamente a crianças com condições agudas necessitam. Se a clínica PEN Plus manter-se unicamente em intervenções clínicas, sim, iremos melhorar os resultados clínicos. No entanto, se PEN Plus implementar intervenções incorporadas nos sistemas de MCH, iremos realisticamente ajudar essas crianças e famílias de forma integral ou holística. E por fim, queria recordar, e já tenho estado a reiterar isto, as crianças, as pessoas não experimentam o sistema de saúde em programas e ensílios. Experimentamos a saúde em sistemas integrados. Não há uma distinção entre serviços nutricionais, infantis ou serviços comunitários. Necessitam simplesmente de cuidados que trabalham para as crianças de forma integral. Aí a próxima fronteira para o PEN Plus, portanto, é efetivamente não a expansão de acesso ao tratamento, mas assegurar que crianças com condições crónicas são detectadas precocemente, encaminhadas com celeridade a iniciar o tratamento e cuidados com apoio domiciliar de forma integral no decurso da sua vida, e a responsabilidade coletiva não é para implementar programas apenas, mas edificar sistemas que são funcionais de forma integrada para as crianças. Muito obrigado. Muito obrigada, Raul, pela impressionante apresentação. Falou de programas MCH, servirem para a detecção precoce e encaminhamento, retenção e apoio pelos provedores. Não precisa de me convencer mais, já estou convencida e estamos a ver agora as crianças maiores do PEN Plus. E veremos mais à medida que nós continuamos a melhorar a sobrevivência através das nossas clínicas PEN Plus. Muito obrigado, portanto, pela contextualização. Vou agora convidar o próximo apresentador, Dr. Bugabe Frank, do Uganda, que vai falar de integração dos cuidados de doentes para doenças infecto-contagiosas no Uganda. Boa tarde. Seguramente estão de acordo que a integração é a via a tomar das apresentações que acabamos de acompanhar, porque essas doenças já estão integradas em alguns dos nossos contextos. Trabalhamos com VIH, diabetes, VIH, hipertensão, diabetes com VIH. Portanto, não há nenhum motivo para, porque os serviços não podem ser integrados. Eu tenho agora a oportunidade de partilhar convosco a experiência do Uganda. Estudos foram desenvolvidos com vista a demonstrar a integração com êxito, mas pouco estava a ser feito. E, como sabem, da nossa perspectiva, DNTs são encaradas como sendo mais onerosas em termos de gestão comparativamente a doenças infecciosas. E indo pelas estatísticas do Centro de Saúde nacionais, vamos ver que as DNTs em 65% são cobertas pelo próprio paciente, enquanto as doenças infecciosas a nível de 40%. E por causa do financiamento para doenças infecciosas, nós vemos que DNTs têm suprimentos limitados, escassez de medicamentos, pouco diagnóstico. As famílias sofrem por causa de despesas catastróficas e encaram as DNTs como sendo bastante onerosas. Portanto, com base nas informações disponíveis, requerem um impulso do governo do Uganda constatou, tendo introduzido mudanças e identificado necessidade de mudança de programas verticais para programas integrados, para que possamos lograr a sustentabilidade, tanto em termos de recursos humanos, como também em termos de financiamento e em termos de fragmentação. E, por conseguinte, o Ministério da Saúde emitiu uma diretiva que levou a esta mudança em finais de 2024. Quando a diretiva foi emitida, tendo em conta a situação prevalecente, foi constituído um grupo de trabalho sobre integração e estratégia. Devemos rapidamente começar a desenvolver modelos de integração de materiais de formação. Claro que já havia alguns aspectos de integração, mas não profundamente arraigados. Algumas críticas tiveram de ser medidas e as clínicas de MCH, claro que estão lá, mas acabamos consolidando diferentes clínicas com clínicas de cuidados com situações agudas ou crônicas. E se for a Uganda, não deve pedir para ir para uma clínica de VIH ou de NTs, mas quer uma clínica integrada. De NTs não tinham clínicas, eram examinados por baixo de uma árvore por idosos e se tem sorte uma vez por mês, mas hoje tem cuidados periódicos, pelo menos numa base semanal, porque já existem os serviços. Portanto, temos que começar a consolidar os registros, as ferramentas de monitorização e nós até concebemos sistemas de mentoria com o apoio dos hospitais de referência e capacitamos. Portanto, temos aqui as 6 dimensões de integração concebidas no quadro de integração, governação, liderança, ação multissetorial, financiamento para a harmonização de conjugação dos recursos, integração da força de trabalho, planificação, capacitação, implementação, harmonização de informação através de ferramentas de dados, cadeias de suprimentos para quantificação e previsão no sistema de procurement. Hoje, os produtos de NTs podem ser integralmente quantificados, sejam financiados ou não. Esta é uma etapa importante. As estruturas comunitárias utilizando os nossos programas de saúde comunitária. Temos aqui os modelos que nós concebemos para as instalações inferiores. Temos ferramentas sanitárias onde nós temos um modelo mixto onde pode tratar casos crônicos e agudos, pessoas com malária, constipação, e podem ir à mesma clínica. Depois temos a clínicas para tratamento de doenças agudas, que são instalações de elevado volume, onde são tratadas os casos crônicos. Nós temos clínicas de cuidados crônicos com elevado volume, onde temos DNTs e pacientes com VIH, onde estão fundidos ou que são separados, mas examinados pelas mesmas equipas. Anteriormente, não eram as mesmas equipas com um grande número de instalações, como hospitais nacionais, hospitais de referência, assim como hospitais especializados. Estes não foram consolidados, dado o seu número, porque temos clínicas que já têm 2.000 pacientes e é difícil fundir uma clínica com uma outra. E este é um trabalho que está em curso. Em termos de priorização de DNTs agudas, olhamos para PEN-Plus para colmatar as lacunas em termos de doenças crónicas, diabetes e células falciformes. E temos 2 centros prioritários onde demonstramos que os provedores intermédios podem gerir estes DNTs considerados graves. Olhando para a equidade de acesso, este modelo muda aquilo que era visto anteriormente como cuidados especializados de centros terciários, que são os hospitais de referência, para instalações a nível distrital. E aqui estamos a olhar para o potenciamento de clínicos intermédios com protocolos de formação para reduzir a distância de encaminhamento e também para salvar vidas. A seguir, seguinte.
The key benefits of integration. From the NCD perspective, there is enhanced NCD screening opportunities. Because NCDs, like I said, have a chance of being screened within the HIV clinic, within outpatient, within inpatient, within MCH services, something that would not happen before. We think there is reduced stigmatization, though this is a bit debatable, because patients with chronic comorbidities can sit together and they are managed together without any segregation. Previously, everybody knew that building is for HIV, this one is for NCD, something that is not there right now. Workforce capacity. Previously, people in infectious diseases were benefiting from a lot of training compared to others. Now all the health workers have benefited from some capacity building, which has helped us in improving expertise, general expertise. There are many other efficiencies, and we think that NCDs also stand a better chance of being prioritized in the near future in the health system needs and budgets. Next. Of course, there are challenges, implementation barriers. We still have diagnostic gaps. We have limited capacity to diagnose some difficult NCDs, limitation in the availability of devices and the diagnostics and equipment. There are resource constraints in financing and the shortage of NCD commodities is still undermining the integration talk and wish that we would want to really push. Addressing this gap, high risk severe NCDs are still less understood. For example, sickle cell disease, type 1 diabetes, rheumatic heart diseases, it's still a challenge to integrate them into this chronic care because not every health provider has the skill and the capacity to do this. So the future focus relies on seeing how we can standardize the protocols and the tools to improve the capacity of these health workers. Next. So our next steps as a government and our partners, we were working to integrate the digital tools. There is a lot of investment there because the paper-based registers were abolished. We needed to train all our health workers. We needed to equip them with tablets and computers so that they can all perform at their level. We need more training of the health workers at the lower level and also semi-specialized levels. We need to advocate for more financing, leveled financing, because NCDs do not have a global fund, do not have a Gavi, and of course some partners come with some conditions. Global fund is for TB, HIV, and malaria, and a bit of the health system, but may not do what we would want in the NCDs. So government needs to do a lot so that the gaps are filled. Next. Thank you very much.
Thank you, Dr. Frank, and thank you for asking for questions. So I think now it's time to open up the conversation and engage the audience. But I just want to talk about a few things that I've learned from your presentation. The first one is we need integrated teams. We need, I think you've demonstrated integrated clinics, but importantly, we need integrated systems. And I think you talked about all the health system building blocks. So I think the integration needs to start from within. So we need to reorient our systems to respond to the growing need of incorporating NCDs into our health systems. With those few remarks, I would like to get a question from the audience. We'll take about 3 questions from each, and then give the opportunity to the presenters to respond, and then maybe we'll take another round if we have time. I stand to be guided. So please, we'll start from this end. Who has the mic? Can you please start from this side? Anyone? Any question from this side? No? Any question from? Okay, there's someone at the back.
My name is Agnes Ampofoje from Ghana. From the integration journey, there is some design which talks about development of integrated models and training materials. Please, I want to know what goes into that.
Who are you directing your questions to?
To Dr. Frank.
All right, thank you. There was a hand in the middle there.
Thank you. My name is Derbo Kadu. I'm from University of Global Education, Rwanda. Currently, I'm working on community-based palliative care. My question is for three of you. Since yesterday also, I never heard of integrating palliative care into pain plus component. I can say thank you for Dr. Rowley. He touched his pillar 3 and 4 are looks like palliative care, because the sole purpose of treating chronic illness is improve quality of life, not only treating the disease. We have to care of the patient, like the whole patient, not specific hard outcome or clinical outcome. So what is the current status of integrating, like adding the component of palliative care into pain and pain plus? Thank you.
So you want all of them to answer that?
One of them can answer it, but it's a really important question because I'm working on it and it's really one of the missing component of this package. Thank you.
Thank you. There's one hand here, and then we'll take the gentleman at the back as the last for this round.
Thank you, Judith from Uganda. The gentleman from Zimbabwe clearly demonstrates and differentiates the pen from the pen plus. And you've told us that the pen plus actually has childhood diseases. Now, I know that when pen plus was rolled out, they sought for people to support the program. But I'm learning from today and from the discussions held that it would be very good to have pediatricians in the different programs. I'm not advocating for this because I'm a pediatrician, but it becomes easy to understand the childhood diseases if the program at least has a pediatrician. And in Uganda, I don't know if it was just by proxy or something, in the two sites, one site had a pediatrician who was already working at that district hospital. So it was a little easier for these other things to pick up. And even the management is a little different. That pediatrician was on site. And so for the other site, which has more patients, about 1,800, we recommended that we get a pediatrician because type 1D, sickle cell disease, and the ones who suffer a lot and crying and families with stress are better understood by a pediatrician who is at least in that place. So whether pediatrician or nurse, a pediatric nurses, it's something we can think through in the program that could, even for centers that haven't rolled out 10 plus, as you're going into the pool to look for people to support the 10 plus program, look at those child-oriented teams. Thank you.
Thank you. Thank you for the remarks. So I'll ask the people who are implementing to respond to that. I think I want to give the last question, and then we go to give the opportunity to the presenters to respond.
Thank you very much. My name is Dr. Didier Chabine. I'm a pharmacist from the DRC. I was hearing that talking about integrated healthcare. So I couldn't see where we talk about research and development approach. Secondly, the role of community health workers and universities, civil society organization, community health workers. But because we are talking about integrated health care, we must see whether the university are involved, where research is involved, and where we have community health workers involved. Thank you very much.
Thank you. Thank you. So thank you very much for your question. I think I would now ask the presenters to respond to the questions that are relevant to them. So if we can start from the end, coming this way. Dr. Peter? Dr. Frank, please continue.
Thank you for asking about integrated materials. I talked about integrated models and integrated training materials. Previously, we had HIV training materials and non-communicable diseases training materials. These materials were crushed and we came up with integrated materials. We developed materials that cover both NCDs and infectious diseases that are involved in chronic care. And the models I talked about are the mixed models, the chronic care model and acute care model, and the vertical models for the national hospitals. May I continue and say something about the gentleman, the pharmacist who asked about the community health workers? Because he didn't specify, but I talked something about the village health teams and community health workers. These are community workers that were also doing work vertically in the communities, either for HIV or for non-communicable diseases. Now we have been training community health workers and equipping them with both communicable and non-communicable knowledge, equipping them with BP machines, glucometers and strips, and when they're in the community, they will not only look out for NCDs, but they can also look out for people with high temperatures and refer them to the facilities. The academia will come in because the academia will need to appraise some of these things we are doing, like integration. We are testing, but they will need to do some studies and guide whether what we are doing is right. Thank you.
Thank you, Dr. Frank. You, Raul?
Yeah,
you have
just
any
a quick comment on the palliative care comment. Um, as I mentioned earlier, this we should heed this advice from these behavioral scientists. Say it over and over and over again until you see the change you want to see. Because I think this aspect of palliative care, not a lot of people are really talking about it and taking it seriously. Not even in the work that we do. So something certainly for us to think about as a community to make sure that that also, that aspect of palliative care, delivering holistic care should include that. And that was the point I was trying to make about supporting children and families at home, but also delivering holistic care. On the community health workers question, let me comment on that as well. In that our work on childhood NCD certainly has strong components of community engagement and involving community health workers. So our programs, the programs we support in India, Nepal, Bangladesh, Zimbabwe, Malawi, all have strong components of community engagement. We involve community health workers in the care, in the outreach, in the identification of children with chronic conditions. And there's, of course, a lot of involvement of community leaders and influencers in the community to address stigma and discrimination, for example. It is quite an important element in in the lived experience of people with NCDs. So in the work that we're launching in Zambia, Uganda, Ethiopia, Cote d'Ivoire, Ghana, and Tanzania, among other countries, we will soon start our work on childhood NCDs. They will also have strong components of community engagement and community health worker engagement. Thank you.
Thank you. Over to you, Alvin. Please, I know you implementers have a lot to say, but keep your responses to 1 minute.
Okay,
Thank you.
thank you so much. Just to add on the issue of community health workers. So, from a practical point of view, in say for example in Zimbabwe, the community health workers they are involved and they are taught on case finding for both pen and pen plus and linkage of patients to care. So this linkage is usually to the first level hospitals or to the primary care facilities. and also follow up of patients who are lost to follow up, maybe who would have missed their appointments from the facilities. Community health workers also play a role in getting to these patients and linking them back to care. So they are strongly involved in both programs. And then I'm going to comment on the issue of pediatricians. So the pediatricians, they are heavily invested as well in the Pen Plus program. To start with, they are involved in the development of the protocols. So whenever, say, for example, in Zimbabwe, we are adopting the Pen Plus training materials, it is the pediatricians who actually sit together with some physicians to really adopt these training materials to the setting of the specific country. And the pediatricians, they are also involved in the training of the healthcare workers. Remember, we are transferring specialized skills from specialists to mid-level care providers. So they are heavily involved and also in mentoring. So ultimately, with the Pen Plus training, we aim to develop some master trainers or some expert clinicians who will also be responsible for training other clinicians at their sites and also really consulting these patients well. So these pediatricians are also involved in the mentoring of these clinicians. And then, so even during the consultations, these specialists, they are also involved in the referrals. So most of these clinicians, they have direct access to these guys. With Pen Plus, we do have a regular mentoring or virtual calls that we do with specialists. Say, for example, with the cardiologists, when we'll be discussing echoes that have been taken by the middle-level care providers within the first-level facilities, discussing with the pediatricians, finding the best management for these patients. So I think it's more like a system that we work both together with the pediatricians and also with the physicians. But ultimately, our aim is to develop some master trainers who will also be able to cascade these trainings to healthcare workers at their sites. Thank you.
Thank you, Alvin. Last presenter, if you have any question, please.
Well, thank you so much. I've been thinking about the question of palliative care integration and basically looking at the current Pen Plus framework. It is mainly emphasizing early diagnosis, linkage to care for those three conditions: type 1 diabetes, rheumatic heart disease, sickle cell disease, and some countries have added asthma. So now when you look at how exactly palliative care comes in specifically for Pen Plus, it's a little bit difficult. But with the current direction where people are beginning to think about oncology, adding childhood cancers, yes, to the Pen Plus conditions, that will be very handy. But even when that is achieved, it comes back to the same thing, early diagnosis, linkage to care. Now, palliative care would fit much more to the Pen side. But if you look at the current models different governments are using, they are looking at the cancers independently, and the cancers are being prioritized under different care systems. For example, cancer of the cervix goes to the obstetrician, cancer of the breast goes to the surgeon. And the models are in such a way that the palliative care now is more centered to those areas, those specific areas. So it's a little bit difficult for now. But with the oncology, as now the thinking, we are beginning to talk about oncology, the childhood cancers from the discussions. I think that may come in handy. But for now, it's very difficult to place for Pen Plus palliative care. It is early diagnosis and linkage to care. Those are the stronger messages. Thank you.
Thank you very much. Thank you very much, all the presenters. I think we've had very strong messages. We've learned about the role of integration in strengthening Pen and Pen Plus. We have heard from successful country experiences where they've integrated, but we have been told of the opportunities for integration in the MCH services. It's quite a mouthful, but MCH services. So I hope all of us today are leaving this room with some actionable recommendations for implementation when we go back to our desk, our offices. So with those few words, kindly join me to applaud our very wonderful speakers as they leave the stage. Thank you very much. Okay, as we go down, they are requesting for a picture, and I'm more delighted to do it.
Thank you, Mary, and thank you for the panel. Doc, there is a photo for the panel here, if you don't mind. Mutengere, there's a photo here. All right. Colleagues, I know time is gone, but we must do a final parallel side events, two of them. One is on the implementation of the GICC and the GPA CCM and the Women Integrated Cancer Services. These are flagship services for cancer from WHO, and they'll be explained very soon. And then those are the projects within the African region. And then the second one is a parallel side event on ear, eye, and oral health. And this is on integration. Integration is the word. Remember even the question that has just been asked about palliative care. We might not have a siloed palliative care or rehabilitation, but those services can be accessed in an integrated fashion within the UHC platform. So these two events, the one that is staying here is the GICC, the cancer program. And my friend, Dr. Dile and Sako Binta will be helping us. And then those who are doing the ear and eye and oral health, when you exit, you take right. Up the stairs is the Mikumi. You will be with Yuka Makino. Dr. Makino will be waiting for you there. We will not have the wrap-up session and closure at the end to give us more time for these two sessions. So from now, it is close to 5:30 maybe. We'll just give them 2 minutes before, so some colleagues who are moving to the eye and ear meeting can walk out. And then you will have, I think, an hour, I think that will be an hour, so that we allow guys who have an evening session also to have it. Okay? Give them maybe a minute.
Thank you very much. I'd like to ask you all to move closer. It's a very big room. This is supposed to be a side event, so let's try to change from the usual setting. So please get closer. Tu me dis, hein? Vous me dites quand on Good afternoon, Excellencies, colleagues, partners, and friends. We will begin the session on cancer control. This session is titled From Burden to Impact, Reimagining Cancer Control Through Action in Africa. My name is Binta Sako, and I'll be moderating this session. please come closer to us as we will begin in just a few seconds. I have the pleasure to be moderating this very important side event, and apologies for the delays throughout the day. This side event is intended to be a bit different we plan it to be a bit different from the usual. Unfortunately, we were restricted, we were constrained with the setup of the room. So it'll be a little bit less interactive, but we'll try to make it as interesting as possible. Cancer is one of the most powerful indicators of how our health systems are performing. It shows us where people are not reached early enough, where referral and diagnostic pathways break down, where treatment is unavailable or very often unaffordable, and where continuity of care depends far too much on status, income, geography, or social support. At the same time, across the African region, we are seeing encouraging progress in screening, in early diagnosis, in organizing oncology services, and in using data to guide decisions. But these successes are still too fragmented and too few. This session is designed to be a sort of a lab where we'll explore those different components. First, we will listen to a person with lived experience to take us through her journey. Then we will see the current reality of cancer in the African region. We will then have the experiences of two countries that are working with the initiatives that are led by WHO. Then we'll have a panel discussion, and we will wrap up our session with a call to action. So let me begin by inviting our first speaker, Karen Nakawala, cervical cancer survivor, Teal Sister Foundation founder and executive director, member of the Commonwealth Task Force on Cervical Cancer Elimination, and so much more. But I'll let her describe her journey through the health system in Africa. Over to you, Karen. She will be joining us virtually. I think we have a little bit of a technical issue, but it shouldn't be long. If there's a serious problem, then we can maybe go to the next session. No, it's coming. I've been reassured. Thank you for your patience. Thank you for your patience. Please let me know if we should have this recording later on so that we can save a little bit of time. I think we are having a bit of a challenge, so we may have to have this session, the testimony later. Apologies for this. We had really planned a very interactive, we wanted to have you moving around with stickers and different posters on the walls. It's not possible. So we've been flexible. And
the Department of Non-Communicable Diseases and Mental Health. So this integrated approaches, the integrated.
Okay. I'd like to call Dr. Dile, who will be showing us a picture of the situation of cancer control in the region. Thank you, Dr. Dile. I think you all know Dr. Dile, our regional advisor on cancer control based in Brazzaville. Over to you.
Thank you so much, Bill. Thank you. Thank you all, dear esteemed participants and colleagues. I'm glad to be here with you today on this side event. Thank you so much for giving your time. So please, the slide. I wanted Karen to start to set the scene because she's amazing really in terms of how she can express how she go through during her journey, but it will be later. They will fix it. In Africa, we have a reality different than many other settings. So we have a situation, a critical situation in terms of cancer in the region. Next. You can see that the numbers that we see for number of new cases and number of deaths. It just tells you that 3 over the 4 people who will have cancer will not be alive in the next 5 years. This is the situation in Africa. 3 over the 4 people with cancer will not be alive. And you can see that the one in top are breast cancer, cervical cancer. So women are in the front for this. Next. We have done an assessment in 2022 to see what is the situation. Next, and we analyze many areas like, next, the policy, legislation. So I will ask you, you know the National Cancer Control Plan, what someone said, if you didn't plan, you plan to fail. So cancer control starts by planification. How many countries? I will ask someone here. Please, the lady who is drinking water, please. Can you tell us, just give a number, how many countries over the 47 member states have a national cancer control plan? Just an estimation. The one behind, please. 10? Okay. Next. We have, in 2022, we had 19 countries. But after many advocacy and support, now we have 28. You see? So we are a bit far. But even this is not so important because you have 47 member states. Next. I will ask question, so please. And how many of them are financing? Because it's not only about having a plan. You know, many countries, I have a plan, I have a strategy. But are they funding this strategy? How many? Karen. I say Karen. Sorry, Benda. Not more than 5. Next. But we have 13. But but 13, they just say they are funding. They are giving some funding. They are not funding the whole plan. So you see, I think that you are not so close because you don't have so much. Next. How many countries have an organized breast cancer screening program or early detection program? Jonathan, are you here? Let me see if he's here. He's not here. I catch you, Jonathan. You're not here. Ah, please. How many have a breast cancer screening or early detection program? How many countries in the region? Over the 47. Next. When we have done the survey, they said 5. But let me tell you that when we explain what is an organized screening program, it's appeared that it's only 1 who have over the 47 organized. Because if you say organized, we need to plan it, to develop guidelines, to have some, to train people, to have everything in place, and also to send reminder, to send everything. You need this, you have reached the age for this screening, you must go to this facility, is organized. What we are doing is opportunistic in many countries, in 46 countries over the 47. Next. How many countries in the region have a free cancer care policy? How many, let me say another name, Balcon, please. They are my people, so they will respond. Balcon, it's mandatory to you to respond. How many people, how many countries have? 3? 3 cancer policy. Yes. 15. Next. I think you saw the report. No, it's 18, but this 18, when we analyze again, we saw that they have just some of them are funding, for example, Senegal, we can say they are funding childhood cancer. We can say Niger, they are funding women cancer in terms of diagnosis, treatment. Burkina Faso, we can say they are funding radiotherapy, all these things. You see, some countries, Paul, Zambia, what are you funding, for example? The treatment, you see? It's not the comprehensive package, you see? Some are just doing the screening, so it's next. In terms of diagnosis, next. For you, how many, the number of pathology lab and the availability of immunohistochemistry? I think that you cannot even imagine. Next, I will go. When you look at the pathology services, we can see that 63% of the pathology services are only in 4 countries. Can you imagine? You have only 5 countries that reach even 1 device, one lab per more than 100,000. So it's very, very few. How can we do the diagnosis if we don't have pathology? Immunohistochemistry, we have only 26 countries over. So we have 16 countries that don't have any immunohistochemistry in the country. Next. The mammography, it's for the screening. Breast cancer screening is mammography, the standard. How many countries have? Simo? Next. They have, most of them they have. But the problem is, when you look at this, we see that most of them, like even, you're just 6 who have 5, who have 1 device, at least 1 device, for 200,000 women population. So no screening. Next. Next. for in terms of treatments, radiotherapy next, because you know that radiotherapy is essential for the treatment. We cannot cure cancer, solid tumor without having radiotherapy. Next. Look at, we can see that it make progress. In 2022, you have only 9 countries, it depends, 9 who have the new generation, and 14 have also. But you see now we have 29 that have access to radiotherapy center. So a bit progress. Next. But there are still very few, there are still very few. So because of all of this, you know, we have problem in terms of diagnosis. We have problem in terms of treatments in the region. So we need to focus on what is feasible in terms of cancer intervention. It's prevention. It's why we designed this project, Women Integrated Cancer Services. WHO Afro designed this project funded by our donor Roche to support the screening, the early detection of breast and cervical. It's about to reduce even the new case coming. We don't want anymore to have women with invasive cancer or advanced cancer because you don't have what to diagnose, you don't have what to treat. So it's better to prevent, to come before, because you know that cervical cancer is avoidable. So why we have the highest burden globally for a cancer who is avoidable. So it's why we have this project. And I will let my colleague, I think Cote d'Ivoire will show you what they achieve in terms of weeks project implementation. You will understand the whole project with them. I think. Next. Thank you.
Thank you. Thank you very much, Dr. Dile, for this summary really description of the situation of cancer in our region and how, especially how women are receiving so little care. Before we go to our next session, I have a small announcement to make here. Someone has lost their phone, and if it's one of you, know that it's at the secretariat room. That room is called Sadani. So if you or anybody you hear of has lost their phone, please, it's available in this room. So now I'd like to move to the next session. I don't think the video is yet fixed, but we'll continue with our session. Is it good? Okay, so maybe I'll let you begin with the video, and then we'll move on with the rest of the program, please.
Good day, everyone. My name is Karen Nakawala, and I'm a cervical cancer survivor from Zambia. When I speak about cancer care in Africa, I don't just speak from statistics. I speak from my very personal journey, a journey that started in a gynecologist's office with words that I never ever expected to hear in my life, with words that no woman should hear. She said, "Karen, you have cervical cancer." And in that moment, my world stopped. My world shattered in a million pieces with no hope of being put together. And I remember the silence after the diagnosis. It was heavy. The disbelief, the fear that gripped me. And my first thoughts was not about treatment. My first thoughts was about my children, my 2 daughters. Would I live to see them grow? Or would they be left alone? I have never been so terrified of dying, but more so terrified of dying and leaving my children without a mother. And sadly, that is a story of many a woman that is diagnosed with cervical cancer in Africa. The days that followed were a roller coaster of emotions. I was angry. I was sad. I was afraid. I was desperate. I was desperate for any hope, any treatment, anything I could get. And I realized that the cancer was not just a disease in my body. It became a shadow over my family. Every appointment, every test carried the weight of uncertainty. Cervical cancer affects women across Africa in their thousands in ways that are deeply personal and often humiliating. The symptoms can be embarrassing, leading many to hide their condition. Silence becomes isolation. Non-disclosure becomes self-stigma. And women and their families carry the burden quietly, most often without any support. My journey showed me how cancer ripples outward. It affects households. It strains finances. It tests relationships. And it isolates women from their communities. I have seen women lose hope, abscond treatment, and I have worked with women who give up and they just decide to go home and wait to die. I have seen families torn apart, marriages break, and lives lost from cervical cancer. I have seen shame that women carry, and these are not unique stories. They are realities that need to be shared. However, in all of this, I have seen hope. I have seen resilience and courage in the survivors. If we concentrate on looking at graphs and numbers, we risk forgetting the human cost. But if we listen to lived experiences, we can design cancer care that is compassionate, that is accessible, and culturally grounded. Governments, communities, together with survivors, must work to co-create solutions to cervical cancer. Because cancer care is not just about treatment. It is about protecting that woman who isn't just a pillar to her family, but the glue that holds her community together. Ladies and gentlemen, cervical cancer is a human rights issue. It is about humanity. It is about dignity. We cannot let women continue dying from a cancer that is preventable, especially when we have the tools, and lived experience being among those tools. As you deliberate, I want you to remember that behind every statistic is a heartbeat. Behind every data point is a human story. Therefore, let us honor these stories by shaping cancer care that sees the person and not the disease. And because solutions must be rooted in the voices of those who live them. Make this personal, because your loved one could be the next one walking my painful journey. I thank you.
Thank you very much, Karen, for this powerful testimony. We wish you were here with us. Thank you for grounding us in the realities of the issue that we're talking about today. And thank you so much for reminding us that behind every statistic, every number that will throw at you today, there is a person, a life, a family, your kids. community that love you. And this is, yeah, it's very touching. Thank you so much, and we wish you were here with us. Sorry, it's a bit emotional as well for me. I'd like to, now that we've had a picture of the situation, we've seen the statistics, and we know that behind those statistics there's a human. Let's come into the middle and see what countries are actually doing through the different initiatives that we talked about. And the first I would like to invite is Dr. Paul Kamfa, a gynecology oncologist with over 14 years experience in women's health and cancer prevention and treatment from Zambia. He will share with us the experiences from his country on cancer control, highlighting the successes but also the challenges. Please come to the floor. Thank you.
Thank you so much. If you look at the statistics, we have been recording 9 new cancer cases every day in Zambia. And sad to say, 6 of those women, they die. And yet this is a preventable disease, even a disease which we can eliminate. Let me try to take you through the journey of how we found ourselves here as Zambia, looking at 20 years where we are coming from. Next slide. We started the journey, next slide. We started the journey 20 years ago in 2006. During that time, we were recording 53 women in 100,000. And this was compounded due to the HIV synergy, because at that time, our prevalence in terms of HIV was standing at 16%. And according to the stats during that time, the women were 3 times at risk of developing cervical cancer. Now, this has come to 6 times at risk of developing cervical cancer. So during that time, we had a screening gap. It was only 5% of the women who were screened. And the biggest issue was inequity. And when you look at cervical cancer, it is a disease characterized by inequity. Next slide. So, that is trying to tell us the journey where we are coming from, starting from 2006, when we had that high burden, up to 2026, the impact that has occurred. Throughout, we have managed to screen about 2.1 million women out of 5.75 million women. And when it came to 2019, during that time, WHO started talking about cervical cancer elimination. We had to embrace in 2021 the strategy to say, let's come on board in as far as the cervical cancer elimination strategy is concerned. All along, we were doing the VIA, but come 2021, we had to embrace now screening with HPV DNA. And we started screening at 10%, and every year we had to move to 10%. If you look at what happened, we decided to integrate the HIV screening services into, we thought of integrating the cervical cancer screening services into the HIV. And we thought that was feasible. At the same time, it was something that we can scale. Next slide. So, in order to scale that, there was also another thought about just the system integration. We thought the human resource could also be integrated. In this case, because we had the biggest issue in as far as treating of the pre-cancer cases was concerned. And because this was a preserve of the medical doctors and particularly the gynecologists. So what we did, was to start now training the mid-level healthcare workers, in this case the nurses, to start doing LEAP in order to treat precancerous women. And it is one of the model countries here in Africa, the nurses doing LEAP. If you look at all the sites that we have, from 2006 for the past 20 years, we managed to train 760 women who could help in treating cervical cancer using the ablative method. And all these were going through systematic weekly review with regard to their images so that they could reach the clinical competence. Next slide. Sorry about that. I think they moved quite fast. Next. So, what we did was what is called strategic integration. And remember the strategic integration, we wanted to start with women who were already engaged in the healthcare. These were the HIV positive women. And already there was that existing infrastructure. And what we thought was that this is the only way that we are going to have that comprehensive improvement of women care. But we didn't just want to stop with that. We wanted also the general population to benefit. That's the reason why we have now managed even to reach 2.1. Next slide. So if you look at the picture on top, where we are coming from in 2006, it's all red. There is only one dot which is in the middle. That was the first clinic which was in 2006. Look at the entire map. By the time you progress in 2025, it's all green, meaning that we have got now 522 clinics which are able to screen and treat. And more important, there is that improvement in as far as linkage is concerned, because we don't just want to screen, but we also want to link women to care. Next slide. Because we had to embrace the WHO cervical cancer elimination, which talks about screening 70% of women with a high performance test, we decided to start screening now with HPV, and this is how we have fared. Starting from 2021, we have managed to screen about 320,000 women using HPV. And the positivity rate for both HIV negative and the general population has been found to about 34%. Next. Why has this approach worked for Zambia? Of course, it's because of the leadership, both in the government as well as the local leadership, which has been coming from the traditional aspect, coupled with community mobilization and strategic training and mentorship. Next. There are maybe 2 or 3 lessons that other countries can get. One of the important lessons is piggybacking on whatever you have. What we did was we had that infrastructure and we had to piggyback on that. And we didn't want even to buy machines for us to start using HPV testing. Already the HIV program and the TB program, they had those machines. They were the high throughput. We just had to piggyback on that. It is one of the things that almost all the countries require to learn on that. Again, mid-level empowerment, in this case, the nurses. Remember, they are the backbone, they are the majority. So we thought we need to formalize the task shifting, not just the task sharing. And this has worked out for us. Next. There are a couple of challenges. Even when we say we embrace the WHO acceleration to eliminate cervical cancer, One of the strongest challenge that we have been having is the supply chain in terms of having that consistent and reliable HPV test and consumables, as well as the sustainable financing system. Reason being is that our program, the prevention, was highly financed by the donors. By the pulling out of USG funding, colleagues, it has hit us badly. Next. The best practices that we thought we need to share is integrate and decentralize. Why should we integrate? It's because integration is not a strategy, but if we want to say we are on the road to eliminate cervical cancer, that is the way to go. And the other form of integration, human integration in this case, task shifting, and you make sure that the community is involved at large. And more important, if you have to go the route of testing using HPV, there is supposed to be a strong strategy in as far as procurement and strong supply chain is concerned. I thought these should be some of the lessons that we should share coming from the Zambian perspective. Thank you for listening.
Thank you very much. This is good lessons that you're giving to us. I would like to invite Côte d'Ivoire to also share their experience. I'd invite all the participants to write your questions because we will have a small session where you can ask the countries about, dig deeper into their experiences if you need. So it's my pleasure to invite Dr. Simon Pierre Boni. He's a medical doctor and epidemiologist from Côte d'Ivoire with expertise in cancer prevention. He has supported HPV vaccination, cervical cancer screening, HIV and cancer research, and we're delighted to have him with us share his experience. Over to you.
Thank you. Good afternoon. I'm delighted to be here to share Côte d'Ivoire experience on WICS projects. Next. So before this fantastic project like WICS in my country, NCD screening services were fragmented, urban-centered, weakly coordinated with high loss to follow-up rate, highlighting the needs for integrated and district-level solutions. Next. So WICS projects focus on integration, capacity, quality services, strong referral systems supported by data, community engagement, and psychosocial support to improve patient-centered outcomes. Next. So here are early results from WICS implementation in my country, and we can see improved availability and integration of services. Irrespective of health districts, we see increase of screening uptake over time, reaching 12,000 women with well-performing CC, cervical cancer, HPV-based screening cascades at this slide. So, encouragingly, we also observe that other women with abnormalities, cancer suspicion, hypertension, diabetes, and depressive symptoms almost were or are completing the care pathway, indicating strong continuity of care. Next. Yes, Wix delivers results because it strengthens real service delivery systems. Success comes from district ownership, practical implementation, continuous support, referral systems, and also a strong coordination between communities and providers. So these are integration rather than creating parallel systems. Next, please. Yes, results are encouraging. However, we have some challenges that remain. This includes ensuring consistent availability of commodities, strengthening referral and data systems, maintaining quality as services scale up, and also sustainability and equity issues, particularly financing and access barriers removal, also needs continued attention. Next, please. So, the Cote d'Ivoire experience showed that supported and targeted district support translates policy into real service delivery gains. So, moving forward, the focus is now on sustaining ownership, institutionalizing integrated supervision, strengthening systems like digital tracking, scaling up services, scaling this model progressively while improving patient navigation and linkage to care. So I would like to thank you again for this opportunity and your attention. Thank you.
Thank you very much, Dr. Simon. We may take, let's say, 2 questions before we jump into the panel to allow our participants to be a little bit more active. I feel that the tension is going a bit low. So are there any burning questions for the 2 country representatives that you have at your disposal to learn a little bit more from their country experiences? Any questions in the room? Okay, are you too tired? Yes? Go ahead.
Yeah, I would love to hear, this is Gene Bookman from Boston. I would love to hear more description from Cote d'Ivoire about how the breast and cervical cancer services are organized together in WICS. And with a little bit more detail about, do you do breast ultrasounds, biopsy, for example? What level of cervical cancer services are there? If I understand correctly, that this is a model that's integrating both, yeah. And at what level? What kind of facility level too?
Another question? Dr. Sidi? Oh, okay.
Thank you very much. Sorry, it could concern the madam who presented about the statistics of cancer. Yes, for example, when you talk about the coverage of cancer units, treating units, a country like DRC, if you have one unit in Kinshasa, for example, it can't cover the whole country, you see. So I would like to further get more in knowing what is the percentage of those centers taking care, taking in consideration the needs of the whole country, not only the presence of a unit of a center, and consider that the country is covered. I think it could be quite not well to consider that. Thank you.
Thank you. Go ahead.
Thank you so much. My question goes to Zambia. How you manage to organize the logistics for HPV? How you manage to do the procurement for the country? Thank you.
Okay, thank you. We'll have to wait after the panel discussion. Please note your questions. I'll let the two countries respond, Dr. Boni and then Dr. Kampwa.
Okay. Thank you for the question. So the question was how screening is organized in my country for this experience. Correct. So before this experience, cervical cancer screening services were offered mainly in urban centered area. So as per this project, we bring screening, cervical cancer screening, and other NCDs, NCDs such as breast cancer, hypertension, diabetes, and mental health assessment at primary healthcare level. After training of health workers, the model consists on offering this system during the unique visits to women. So cervical cancer screening was done through HPV screening and VIA, breast cancer using clinical breast examination and so on. So once a positive case is screened at this PHC level, the treatment is either done on site if it's about thermal ablation, or patient was referred for a biopsy, for example, for breast cancer. And once results available, patients come into PhD level to show the results, and the referral system is established for her. How globally, overall, the system is organized. The model consisted on offering a one-stop model at PhD level and a patient navigation support women who are referred to other to higher level of the system for diagnosis, for further diagnosis and treatment.
Thank you, Dr. Paul. I think you can respond to the next question.
Hello. Thank you so much for the question. Let me start with how the procurement is being done. As Ministry of Health, we are procuring this centrally. And the money has been coming from Global Fund. So if you look at the last GC7, which is coming to an end. We had done the forecasting and quantification of how much HPV tests we required, and we had to input that into the Global Fund. Equally true is this GC8 which has started. Again, we have inputted how much and how many testing kits we require for the next 3 years. If you remember, like what I mentioned at the outset, we have been very strategic in the sense that we have just been increasing 10% of the eligible population who require to be screened using the HPV, such that by the time, our projection was that by the time we are reaching 2030, we shall be at about 60 and 70%. So we have been very, very strategic. And how the procurement is being done, it's being done through the WAMBO. If there is somebody who is very familiar with Global Fund, there is the WAMBO system, which helps us in the procurement. And what had happened was that through UNITAID, there was a negotiated price for the HPV kits. We have got 2 centralized platforms and 1 near point of care. The 2 centralized platforms, they are the high throughput. So there are these kits which we use coming through the Hologic Panther system, where we have about 10 machines dotted throughout our country. Then we have got the other consignment which come from Roche. In this case, we use again the high throughput machines, which are the 4800 as well as the 6800. In total, we have got 13 of these machines. Then when it comes to near point of care, where we are using CFAID, where we are procuring from CFAID, this is the one where we are now using the Gene Expert. So we have got 327 Gene Expert, but the only ones that we are currently utilizing, it's 70 Gene Expert machines. And what we have been doing is that almost all the procurement of the kits, they come through the Zambia medical medicines and medical supplies. And then the distribution is done from there up to the last mile.
Thank you very much, Dr. Paul. And the last question, Dr. Dile, before we move to the next session. And just to announce that we will be having a cocktail after this event, so please stay with us. Over to you, Dr. Dile.
Thank you. Thank you so much. So for DRC colleagues who ask this question, I can respond in French, but I think you have your... Okay, so device for 250,000 population, if you took it by population. So you see that DRC, you are more than 100 million. And with one device, you are very far. But let me tell you that in the region, none of the country reach this norm. None. You don't have any reach norm. It's one device for 250,000 population. Thank you.
Thank you very much, Dr. Dile. So now we'll be entering the almost last segment of the side event, which is going to be a panel discussion. And I'd like to invite representatives from civil society, Benda Kitata. She's the founder of Kilele Health Association and lead of the African Cervical Health Alliance. Welcome, Brenda, and please have a seat. And I'll also like to invite a representative of the donor community, Roche, here present. Please come. And I will let you introduce yourself. Welcome.
Good evening, everybody. My name is Dr. Njeri Gitao. I work for Roche Africa as a health access and policy partner for East Africa.
Thank you very much for participating here with us. I think Dr. Dida, you could have stayed up with us to ease some transitions as well. So in this segment, we don't improve services. We don't change a system with one partner alone. We've talked about the importance of multi-sectoral collaboration, of different stakeholders being involved in the policies and in the implementation of our programs and projects. And here, for cancer, especially integrated cancer services, I think it's important that we bring all these different actors at the same table. It was supposed to be a round table. Thank you very much for being here with us. So if you allow me to begin, I'll begin with civil society, Benda, and ask you, how can civil society organizations ensure that communities are effectively reached, that we are sure to create demand and ensuring that their voices are heard?
I believe it's working. So good evening, everyone. And I know this is the last session for the day. So I can imagine you also have had quite a long day. Civil society, we're known to talk when you get the mic. So you'll forgive me for this one. Your question is how we can get the civil society to be more integrated, more involved in the solutions that we are hearing about. And having attended this now for the second day, one of the things that stood out a lot for me was that most often programs are provided or are put together for the community. And most often communities are not invited on the table to have a conversation around what does co-creation look like? What are the burning issues? If you recall the video from Karen Nakawala, who is a member of the ACHA, the African Cervical Health Alliance in Zambia, she talked about her biggest concern was not how long the treatment was going to take or what it was going to cost or what distances she would have to travel for her to get treatment. Her biggest concern was, who will take care of my children? How will I go through this? Might I die and leave my children with no one to take care of? And that's the one thing that as civil society we bring on the table. Lived experiences that inform the decisioning on how services should be rendered, how products should be introduced, how interventions should be modeled around the real needs of the community. As civil society, we sit at the intersection between the interventions and the trust in the community. Most often, our people will be making their decisions on how they interact with the healthcare system based on whether they trust the healthcare system in the first place. And one of the things then that we bring is a civil society, because we're at the last mile. We bring that trust element. I know it's very hard to measure trust, especially when we're talking epidemiology and all the big words that we bring in the table. But when we think about trust, we're thinking about that woman who needs to be reached, and she needs to understand. So awareness, education, and understanding of why she needs to take action. She also needs to understand herself to know what integration means. So that when she gets into the clinic, maybe you created awareness for cervical cancer. She also demands for that service for breast examination. So that integration works both at the service provider, they've been trained, but at the community where the woman is demanding for these services. Equity is the second thing. At this point in time, when we're looking at coverage, for example, for Zambia, that all the districts are covered, and we could see with the map, the red dots versus the green dots, and the whole country covered. The question I'll ask for Zambia and for the other countries is, what about people living with disability? What about the deaf mute? Are they being reached with these services? What about that woman who lives so far away and is not able to access what Dr. Dile has spoken about in terms of the ratio of one machine to 250,000? This is where, again, civil society comes in. I have seen in our programming in Kilele Health, as well as in the African Cervical Health Alliance, where people with lived experience are saying, wait a minute, I'm going to learn sign language. so that I start sensitizing the women who cannot be reached by the conventional medical approaches, to start sensitizing them on the need for screening, to start sensitizing them on the need for follow-up and ensuring adherence to treatment. The third thing that we bring is that knowledge of design so that it's responsive. Programs are responsive to the community needs. And so that when we talk about healthcare financing, for example, most often we will see healthcare financing from a point of providing the interventions, providing the technologies, providing the drugs, but nobody is talking about the out-of-pocket expenses and how they can be provided for. And this is not asking for a donation. Here we're saying, with that lived experience of the woman who has navigated the healthcare system, they are the first port of call to explain where did they feel they wasted resources, how could they have navigated faster in that system. Civil society brings this knowledge and can be useful to the system to ensure we reduce wastage, duplication, and we increase efficiencies. Lastly, as civil society, we are constantly talking about our lived experiences. But I want us to start looking at that as data that is credible, that can be utilized to hold governments accountable to investments, but also to hold women responsible for action. And this accountability is two-pronged. Where we're looking at the data in terms of community-led monitoring, we're able to look at how do we ensure the gaps are met by the system, and so that women are able to access these services, but also accountability on sustainability. Again, because when the funding is done, when the program is done, when everything has been done for the community, and that is wrapped up and we've clapped for ourselves that we've achieved what we set out to do, we always leave gaps in the community. But this is where civil society says, I live in this community, we have this knowledge, we'll continue to create awareness in places that we live and places that we work, so that women continue to come to the facility as opposed to relying only on outreach models. Suffice it to say, from a civil society perspective, when we're measuring access, we're measuring the outcomes, number of women reached, but also number of women completing the service and the access to services. But we are also looking at how well do we trust these health systems to deliver long beyond the funding cycles. It's important we engage communities. Thank you.
Thank you very much, Benda. I think you deserve the time, the extra time. You touched on really very important elements, the trust, the equity, and without the contribution of the community, nothing is done at a sustainable level. So thank you very much for these elements and your experience in working with civil society. Now I'd like to turn to our donor community and ask how can donors and also private sector in general better coordinate investments and partnerships to make sure that we do not duplicate, but then we fill the gaps where they are. Over to you.
So thank you very much. So how can private sector and the donor community and government better leverage investment in NCDs? So speaking from a private sector perspective, but also having worked with the donor community, I think one of the things we always need to remember is we have to make sure that this conversation is understood across. We keep talking about NCDs being a multi-sectoral investment, multi-sectoral approach. And one of the things that we always have to keep saying is, what does it cost our country? What is the cost of the GDP of our country? So part of the data that we have as Roche is that breast cancer alone results in about a loss of $10.3 billion in GDP in just about 7 African countries. Just to mention a few: Kenya, Tunisia, South Africa, so Cote d'Ivoire, across many African countries. So when we look at this and when we look at how should we invest, I'd love to quote the Lusaka agenda, where we talk about one plan, one budget, one monitoring and evaluation framework. And really, if we look at the WIC model, which is what we're talking about here today, we can see a part reflection of that. And just to highlight some of the examples, for example, if you look at the investments in Cote d'Ivoire, Cote d'Ivoire, based on Roche investments, we have what we call the basket deal in Cote d'Ivoire. And Cote d'Ivoire basically did a debt swap, and from the money that they saved, and in collaboration with Roche, were able to create a basket deal where Cote d'Ivoire was then able to use those savings to invest in cancer care and treatment. Part of that is some of the success that we're seeing in the WICS project. If we look at data integration or one monitoring and evaluation framework, we see this happening across several countries. We see this happening in Kenya with the data being integrated into the DHIS system. And we see several other areas where we have built capacity across board. So when we're talking about efficiencies and economies of scale, and when I look at the WICS model, we can look at it both from the demand side and the supply side. And we find that from the demand side, based on the integrated approach, working together with various governments across Africa, where Roche is present, we are meeting the patients where they are, right? That's the demand side. They need care, they are the community, they are the health facility. When you look at the supply side, it's in terms of optimizing the human resources that are very meager in our health facilities, especially the public health facilities. So we're optimizing the resources, we're optimizing the money that is available, and we're putting together, we're bringing these together so that we can optimize resources and being able to measure that. What does it mean at the end of the day? So in Cote d'Ivoire, there's a 56% increase in breast cancer survival rate. In Ghana, for example, we have changed about 12% of the national oncologists. Just to mention a few. Thank you.
Thank you. Thank you very much. Thank you. Thank you very much to our panelists. We are running, as you know, out of time. So I'm going to have to shorten the session, unfortunately. But as mentioned, there will be a cocktail. It'll be also an opportunity to meet with the speakers and to ask additional questions and to have a full conversation. Thank you so much for Benda and representative from Rush for being here and for adding your voice and your perspectives as well to the conversation. So now I'd like to invite Dr. Dile to give us the takeaways of this session and her recommendations and next steps. Thank you very much, and over to you, Dr. Dile.
Thank you, Dr. Thank you again for our panelists. Thank you so much for your participation, and thank you for the audience to still be there after a long day. So today we can say that we listen to Cote d'Ivoire. Cote d'Ivoire said, okay, are you putting the slide? Yes. Don't forget the group photo after. So next. So what did we achieve today? We have the project. We understood what is the current reality of cancer in Africa. We saw some few progress. It's true, but you can say it's progress. Yes. Let's be optimists. We identified the remaining gaps, like our friends say, radiotherapy machine, and we agree on some priorities that all of you show, give some priority action that must be done. Next. Cote d'Ivoire demonstrated that a multi-sectorial approach and a strong collaboration lead to improve outcome cancer prevention and care. Zambia has demonstrated that integration, NCD, non-communicable disease and communicable disease, leadership, supportive policies, but also these policies will lead to task shifting. It's very innovative. Let me start as I'm surgeon, I'm oncologist surgeon. Let me tell you that letting nurses or midwife doing lip is very innovative. Because even surgeon, not all of them is doing, because the cervix is bleeding a lot. So it can create all this can create an environment to enable effective cancer control. 1 doing screening, 2006 and 2025, more than 500 center. Paul, congratulations. Please, I want you to upload to Cote d'Ivoire and Zambia and the other who are doing their best. Bender, the civil society, told us that integration must be at community level also. Sensitization is important because it's not only about screening, it's about follow-up. Because we can screen 1 million women. If we didn't follow up, they will disappear. Because in Africa, they have many things to do. It's their cervix or their breast, but they have to cook, they have to work, they have to go to farm, they have to do a lot of things. So it's your job to screen, but it's also your job, healthcare workers and politicians, to make available, to make them to follow up with these women who have been screened because they need treatment. Civil society also tell us that all this must be done with trust, equity, and don't forget the sustainability of the action. And the health financing is not only to give drugs and services, no. Look at these women who need to pay out of pocket for chemotherapy, for radiotherapy, for example, a lot of money, $10,000, $10,000, something like this. The donor show us, told us, and thank you for supporting a lot in Africa. Really, I want to applaud to them because they are doing a lot. It's a lot of countries that they make accessible target therapy for breast cancer. We cannot even imagine me in my country that we can have access to target therapy in Africa. But they support this in many countries. And she told us that the government must commit. We have the Lusaka agenda. Don't forget, it's not always asking the donor to do no. We need to do our efforts to optimize the resources. Next. So the follow action that I want to do for the government, make cancer a national priority. Because when we make available cancer services, it also helps the NCDs, not only cancer, and the other services. The domestic resource must be mobilized for sustainability of the action. You need to integrate services. Zambia showed a good example. We have the services. Please use them to do many other things. Train people. But before, we need to invest in these people to train them. Essential medicine and the data. How can we measure what we are doing if we didn't have data? But all this need strong leadership, as we said. Next. The because we need to reduce the cancer burden in your countries. For the partner and donors, I knew that you are doing a lot, but please continue. don't don't be tired for us, if I can say in my French English. Please continue, because we need you. Because all in our countries, everything is priorities. We have security, we have education, health. Everything is security, is priority. But when you are going to the countries, please align also to their priority. Don't say, no, we are just investing in this area. Is this area? No. Look at what they plan and support them. And we want you also to be in a coordination together with the other donor. It's not like going alone. If someone is doing the same in the area, please work together. Together we can do more. Next, for us, we are already committed. We are here today with all of you. We will continue to lead and to provide the global and regional leadership and normative guidance. We will continue to do our best to generate data and evidence and standard to inform the decision of the government. We will continue to bring together countries as today, as these 3 days, and partner for coordination and alignment. We will continue to support our member states and beyond to build the national capacity. We will continue to monitor the progress, because we want in 2030 to have at least some countries who reach the target of the cervical cancer elimination and take the pathway for the global breast cancer initiative, because we are the region who have the highest burden of cervical cancer and the highest mortality of breast cancer. So together we can build something, but only together. Thank you.
Thank you very much. Another round of applause for our panelists. And as announced, there will be a cocktail. But before that, can we take a group photo? The photographers. Please, the photographer.